Assalamu alaikum and welcome to this lecture on shoulder dystocia. Unfortunately, we cannot have our skills session in the skills lab together, looking at how shoulder dystocia actually looks and can be relieved. But in this lecture, you get some graphic images and you find that you can also try that. When you're back at the university next year or in the summer, you can then have a go yourself and have a look how these maneuvers work. First of all, what is shoulder dystocia? Shoulder dystocia is what requires more obstetric maneuvers after delivery of the head. So the head is delivered, but the anterior shoulder is trapped behind the symphysis pubis. So it's a bony obstruction in the delivery process. And this has to be very clear to you when you talk about shoulder dystocia, that this is a bony obstruction in the delivery process. It is rare, so the prevalence is less than 1%. So what actually happens? This is a picture of a shoulder dystocia, or a drawing how it could look. You find that the head is delivered, but the shoulder does not come after with the shoulder dystocia. So this has to be very clear in your head, because all you have to do is to kind of disimpact this anterior shoulder from behind the symphysis pubis, and this is how you're going to help to deliver this baby fully. What are the complications or possible complications of shoulder dystocia? We have, first of all, maternal morbidity, and also we have perinatal morbidity and mortality. Maternal morbidity includes typically postpartum hemorrhage, as well as 3rd and 4th degree tears, so genital tract trauma. And the genital tract trauma is not necessarily due to the size of the baby, but it is due to the maneuvers that are done. Finally, the perinatal morbidity and mortality is even of more concern. And they include typically the brachial plexus injury. And you can see there's a big variation in the percentage of cases that suffer shoulder dystocia who will then go on and also have brachial plexus injury. And thankfully, only 10% remain permanent neurological injuries. 90% actually resolve with time. So we're going to talk about how this I'll have some pictures to show you how it comes about to have the brachial plexus injury, because it's important to know that also in your management. But you can see here that the baby will here shows the right arm of the baby shows Erb's palsy, which is due to brachial plexus injury, and you can see that the baby will not be able to move that arm, whereas the left arm is moved around normally for this baby. Other complications are clavicular fracture, humerus fracture, and also death. So the reason we get this brachial plexus injury is because where the you see in this picture, you can see that the shoulder is stuck behind the symphysis pubis, the pelvic bone, and then the area of but the head is delivered, and in between this area, between the delivered head and the shoulder, is the neck, and there lies the brachial plexus. And if the shoulder is stuck behind the pelvic bone, but you kind of pull on the head, then you stretch this area of the nerves, and this is what leads to brachial plexus injury, the stretching of the head. And we have here another kind of picture of that. You can see in the picture at the bottom, you can see this. The shoulder is stuck behind the pelvis bone. It doesn't move, and the more you stretch on the head, the more you will kind of be cause a brachial plexus injury to this child. Okay, so the other way of causing a brachial plexus injury is the pushing of the mother, so the propulsive action of the contractions or the pushing. And so therefore it is very important, once you realize you have a shoulder dystocia, that you tell the mother, stop pushing, no pushing now, because the more she pushes this shoulder against the symphysis pubis, but this will not deliver the baby. It will just lead to brachial plexus injury. So this is the anterior shoulder. You can see the posterior shoulder. If the posterior shoulder is affected by a brachial plexus injury, this is not due to the health professional's action. This has got other reasons. So what are the risk factors for shoulder dystocia? We can decide, we should distinguish, look at antepartum and intrapartum risk factors. So if we look at the antepartum risk factors, there's previous shoulder dystocia. There's an estimated weight of more than 4.5 kilos for this baby. Diabetes mellitus is a very important risk factor. Maternal BMI and induction of labor all pose risk factors. Intrapartum risk factors are a prolonged first stage of labor and a secondary arrest in labor. A prolonged second stage where typically you can see the turtle sign. So the patient the mother pushes her baby down, and you can see the head advance, and then it retracts again. And then she pushes it down, and you can see the head advance, and then it retracts again. And this is called the turtle sign. It's very typical for shoulder dystocia in the second stage. You can see it more often with oxytocin induction and assisted vaginal delivery, so instrumental delivery. So this means you've done a ventouse, this head just wouldn't come out. You do a ventouse, you deliver the head, but then the shoulder is stuck and you cannot deliver the body of the baby easily. So we have looked at risk factors. So my question is now, can shoulder dystocia be predicted? Can you actually, with these risk factors that we've discussed, predict which woman will suffer a shoulder dystocia? And the answer to this question is no. This cannot be predicted safely. There's a very low statistical predictability, because about 50% of all shoulder dystocias, for example, occur in babies that are less than 4 kilograms. So if we look at something that people regard as one of the most important risk factors, which is a baby above 4.5 kilos, we can then see 50% will happen to babies who are only less than 4 kilos. So only 16% of shoulder dystocias can be predicted with these risk factors that we've enlisted, and therefore we can really say it's not predictable. The only patient group in which you have to be very wary of shoulder dystocia are by diabetic mothers. So this is not necessarily gestational diabetes. This is pre-existing diabetes, usually type 1 diabetes. Could also be type 2 diabetes, but pre-existing diabetes is the most significant risk factor here. And this has to do with the fact that these babies are exposed to higher insulin levels because of the high glucose of the mother coming to the baby. The baby produces more insulin to kind of keep their blood sugar in a good, in a normal way, in the normal level. And this insulin leads to accumulation of subcutaneous fat, as well as accumulation of fat in the liver, and a larger liver, and generally a larger abdominal circumference. And this accumulation of fat and can lead to a kind of a larger abdominal circumference than head, leading to shoulder dystocia. So this patient group is at very high risk and has to be always regarded with care. If diabetic mothers appear to have big babies, this has to be regarded with care. So, how can we prevent shoulder dystocia? Because prevention in this of this emergency would be the best kind of treatment. The problem is that this is, again, because it's difficult to predict, it's also difficult to prevent. There's one strategy that maybe regarding women with diabetes, that those women, especially those with type 1 diabetes, but also possibly type 2 diabetes, they should be offered induction a little bit earlier than 40 weeks, so that there's not a chance for this baby to kind of accumulate more fat than necessary. Women with diabetes and an estimated fetal weight of over 4.5 kilos should be offered a cesarean section. But you have to know that 443 cesarean sections need to be done to prevent one permanent brachial plexus injury. And in non-diabetic mothers, you have to even do 3,695 cesarean sections to prevent one permanent brachial plexus injury. Therefore, the American College of Obstetrics and Gynecology recommends cesarean section with fetuses in non-diabetic mothers with fetuses with the estimated weight over 5 kilograms. But really, other international guidelines recommend if the estimated weight is above 4.5 kilograms, you can offer the mother a cesarean section. But you have to be aware, and you have to counsel the mother about this as well, that you will do a high number of unnecessary cesarean sections if you choose this strategy. Women with previous shoulder dystocia do not need a routine cesarean section, but this decision needs to be taken case by case and together with the mother to see what she prefers. Now, let us talk about when we come to actually having a case, seeing a patient who actually has a shoulder dystocia. We have to have certain management principles, which is prompt recognition, and this is actually not difficult. This is an emergency. You come into the room, you see this head looking at you accusingly, and you cannot deliver the body. This is a very prompt clinical diagnosis. You have to have a team approach, and you have to have prompt management with the team. And I will want to mention another term here, that is that you have to announce the emergency. So when we say you have to have a team approach and prompt management with the team, this means that if you are in one room delivering a patient and then you are faced with a shoulder dystocia, the first thing you have to do is call for help. And this help you have to call in a very direct and clear manner. So you don't call, I need some help, please. This is a very vague way. People will not know who needs help, where is the help needed, what do they need help for? No, you have to be very precise and say to either another person within the room, if you're in the room yourself on your own with the patient, you have to come out and you have to call, I'm in room 5. I need help with an emergency. I have a shoulder dystocia in room 5. And then people will know where to come, room 5, and they will know it's about a shoulder dystocia. So it's very important to always be very clear and precise in such emergencies. So this is concerning the prompt recognition, and here you can see a picture of a mother who actually has a shoulder dystocia there. and you can see how the head is there between the between the legs, and how it does not move anywhere, and it doesn't come out anywhere near anywhere near. You also find that there's no restitution of the head, so the head will not restitute, so no external rotation of the head. So you need fast action here. Why do you need fast action? Because you have to remember that when the head is delivered, the cord is compressed. So to have a low risk of any neurodevelopmental problems after delivery of this baby, you should deliver this baby within 7 minutes of delivering of the head. You should deliver the whole of all of the baby. So you only have around 7 minutes. If this is longer than 7 minutes, the risk of neurodevelopmental problems after delivery increases significantly. So therefore, you have to be very quick. You have to call for help, and this has to be in a precise manner, and you have to announce the emergency. As in all emergencies, you should always announce the emergency and say, I have a shoulder dystocia, where in room 5. You have to have a systematic approach, and we are going to talk about this systematic approach in this lecture. And you should never apply fundal pressure to this in this situation. You should never ever apply fundal pressure these days. We know that fundal pressure does not help in delivering any baby, and but can cause problems such as an inverted uterus and problems like that. And also, it's very uncomfortable to kind of press down on the abdomen of a mother, but also it's not effective, and it should never be done. It's actually malpractice to see anybody doing fundal pressure, and you should always stop people when they apply fundal pressure. I know that you sometimes see this here in Gaza on the labor wards, and you should always stop them from doing it, because it's dangerous and not helpful. But if you think about shoulder dystocia and somebody doing fundal pressure, it's extra problematic, because you will just push the baby down towards you will push and compact the shoulder onto the symphysis pubis, and you will cause a brachial plexus injury with such an action. So we have a little abbreviation for our steps that we are going to follow in this in management of shoulder dystocia, and we are going to go through every step. So call for help is H. The abbreviation is helper. Call for help is H. E means you evaluate for episiotomy. An episiotomy does not necessarily have to be done, and it is not done because it will help to deliver this baby, so for the baby to be delivered spontaneously. Remember, this is a bony obstruction, and episiotomy does not in itself help to deliver the baby, but it sometimes gives extra access to the area, because as you saw on the picture, this baby is big, and it kind of covers all the access that there is, and you might need an episiotomy just to be able to kind of do the maneuvers that we're going to discuss. Then you look at the legs, and this is very important. You put the patient down on her back, and you pull up the legs. You hyperflex both legs. This is also called Mac-Roberts procedure. It is not something the patient can do herself. She needs 2 birth assistants, each holding one leg and hyperflexing that leg. At the same time, you have to tell the patient, stop pushing, no pushing now. Then you do suprapubic pressure, and we're going to talk about this. Following this, the E is for enter different rotational maneuvers, and we're going to talk about that. If this did not work, you have to remove the posterior arm or roll the patient over, and we're going to talk about each step in the following of this presentation. So episiotomy we already covered. It is not a relief of the bony obstruction, but it allows more room for doing appropriate maneuvers. So this is the Meg-Roberts procedure. And it is just going to show you how it makes a little bit more room and actually can help to free the shoulder from behind the symphysis pubis. And a large number of shoulder dystocias, thankfully, actually react to and are able to be delivered just with the Meg-Roberts procedure. You can see how the hyperflexion just allows that little bit more room in the pelvis, but you have to put down the patient flat to have maximum effect here, effectiveness. Then you do suprapubic pressure, and this should be done while this should be done at the same time while the Meg-Roberts procedure is also done, so it should be done at the same time. And can be done at the same time. The you can see how the hands here in this picture. You can see the hands are held similar to when you do CPR, and you should do suprapubic pressure for 1 minute in a constant pressure, followed by, if that was not effective, not 1 minute, half a minute constant pressure, and then again another half a minute rocking pressure. So altogether, suprapubic pressure should only be done for 1 minute, and if it doesn't work, you need to go on and do other things. It is important that you do the suprapubic pressure in such a way that you know you want to adduct the anterior shoulder, make that little bit of room behind for the shoulder so that the shoulder can go down and actually slip down the bony obstruction. So you have to do it from the back. So it's very important that you do not do it from the front, because you might exacerbate and make the situation worse from the front. You have to do it in such a way that you adduct the anterior shoulder from the posterior aspect of the anterior shoulder. So here you can see it again. You can see that this patient, that you have the somebody doing Meg-Roberts procedure, and there'll be another person on the other leg doing Meg-Roberts procedure. One person is at the bottom end trying to deliver this baby, and then one person doing the Meg-Roberts procedure also does anterior suprapubic pressure, and it is the person who's standing at the back, at the posterior aspect of the baby, so that it is done in a correct way and can be successful. So you can see easily you need a team in this situation. You cannot handle such an emergency on your own. If this is not successful, you do you go to the next letter, which is E. E stands for enter, and here you can see we have loads of different maneuvers that are proposed to be effective. In fact, we do not know which one is better than the other, and it does depend very much on what works in this situation, or what you are familiar with and what you feel comfortable with. This one you have to stick to. But all of them are actually physically quite demanding. So they are not just, I'll try to kind of press a little bit. You have to be committed. I want to deliver this baby, and really do these with commitment and with force and pressure, so that they can work. With just a little bit of half-hearted I'm trying to, no, this does not work. You have to be committed. You say, I'm going to deliver this baby now, and really apply the pressure as is needed. So they have different names. One is the Rubin maneuver, which is aimed at you enter with your hand, you put your fingers on the posterior aspect of the anterior shoulder, and you try to just move the shoulder down from behind the obstruction. So you do what the suprapubic pressure wanted to do from outside, you now try to do from inside. You can also do the same with the posterior shoulder, and if you do both, so if you try to apply pressure at the anterior shoulder from the back and to the posterior shoulder from the front, then you do a wood screw maneuver. So this is the Rubin maneuver. You can see here how the hand, once you cannot actually reach this, you have to always enter the vagina from the back, from the posterior fourchette, then work your way up and find the anterior shoulder and press it down so that it kind of can adduct and slip down past the suprapubis, symphysis pubis, and you can see that this will require a lot of pressure and force from you. If this is not successful enough, so here we can we have had the anterior shoulder kind of dislodged, or again a way of dislodging it. But if this is not successful, you can use your second arm, your second hand, and press against the anterior aspect of the posterior shoulder, and then move with both hands, try and move this baby and turn it round so that the anterior shoulder gets dislodged. So you have to always remember that the idea is to dislodge the anterior shoulder. So you have to kind of adduct the shoulders and make a little bit of space. This can also be achieved just by rotating the posterior shoulder. So with adducting and rotating the posterior shoulder, you might also be able to dislodge the anterior shoulder. And this is what I was talking about before, the wood screw maneuver, when you push onto the anterior shoulder from the back and onto the posterior shoulder from the front. So you do the Rubin maneuver together with the pushing onto the posterior shoulder and try to move this baby around this way, and you will then if it works, once you've dislodged the baby, you can move it 180 degrees and then deliver it that way. All of these maneuvers need force, need commitment, so that they can be successful. And this is what this baby needs at this time. You can imagine that putting force on the shoulders might lead to clavicular fracture, for example. But this a clavicular fracture often will heal well after birth, but you have to be committed to do this procedure, because 7 minutes is not that long, and neurodevelopmental delay does not heal easily, whereas a clavicular fracture will heal more easily than does not usually carry long-term implications or sequelae for this baby. So this is another picture. This is from when you sit down at the bottom and how you do the wood screw maneuver from the bottom. You push with one hand onto the posterior aspect of the anterior shoulder and with the other one on the anterior aspect of the posterior shoulder, and try to rotate the baby around this way. And here's the reverse wood screw. You can see always, if you have lots of maneuvers to achieve the same thing, you know that not one of them will work, but different ones have worked or have not worked, so there's not one that is better than all the others. Finally, if this does not work, we come to the R, the first R. The first R stands for removal of the posterior arm. And you can do that you can see on the left picture here. Of course, you won't see where the posterior arm exactly is. So you have to insert your hand, your whole hand, at the posterior shoulder and walk down until you reach the antecubital fossa. With the antecubital fossa, you have to flex the arm and then reach the lower arm to grab the lower arm, the hand, and deliver it and make room for the anterior shoulder in that way. You can see that this is quite an invasive procedure and often leads to humerus fractures. But again, you have tried other things. This baby needs to be delivered, and a fracture of the humerus will heal, but neurodevelopmental delay will not heal, and therefore it is important to also, if you want to do this, to show commitment and force so that you can do this procedure well. So here is another, here you can see how the hand will go in. It will reach, you will feel for the elbow, you will flex the arm in the antecubital fossa, grab the hand and deliver the arm that way. If all of this does not work, you come to your last action, and this is the last R, which stands for roll over to hands and knees position. And this is the hands and knee position. And doing this is said to give a bit more room and make the baby actually kind of fall down and dislodge the anterior shoulder from behind the symphysis pubis. Actually, this is what midwives do as a first maneuver, and if they are alone with the patient. And it has also been shown to be effective. And some people say this should be the first maneuver. So really, because really we don't know which is best and which is most effective, but some people say this even should be the first maneuver to do. There are some third line maneuvers which you will find in every book, but many of them should not be done anymore, okay, because they carry a high morbidity for the mother and as well as the baby, and they are rarely used and should only be a last resort. So one is to kind of bending both clavicles, or one clavicle or both clavicles with your fingers, so basically breaking the clavicle of the baby and kind of delivering the baby that way. This is one way. This is an acceptable procedure if everything else fails. But there's two procedures that always you guys mention as a possible procedure, which should not be done anymore and which are actually malpractice. One is symphysiotomy, which is kind of separation of a surgical separation of the symphysis pubis to make room for the anterior shoulder. This carries a very large morbidity for the mother, including bladder injury and rupture, and has rarely seen healthy babies delivered. And the second one is the Zavanelli maneuver, which is means to kind of replace the fetal head within the into the abdomen, then go and do a cesarean section. Again, this will take at least 15 minutes. So after 15 minutes you will have a baby with neurodevelopmental problems following birth. You will also actually, in most of these procedures that were described, you had dead babies at the end. And it causes a lot of damage. It can cause uterine rupture, injury to the fundus, and cause a lot of problems without actually yielding a good result, but causing complications without a good effect. So these two procedures should not be done anymore. So what do you have to think about in the postpartum period for this patient and this baby? You have to be aware of postpartum hemorrhage. Often these patients had a long labor. They often had induction as well, sometimes also instrumental deliveries, and all of this will lead and increase their risk for postpartum hemorrhage, and you have to be wary of that. Also, the neonate needs to be examined very carefully, so you need to call the pediatrician, of course, and tell them what happened so that they can look at the baby. You have to document all your maneuvers and everything very well. And this is especially important as often neurodevelopmental delay only presents later in a baby's life. And at that point, you will not remember what actually was done and wasn't done. So if you have documented shoulder dystocia, one called for help, who arrived, and everything with minutes documented, then you can show it was managed properly, but unfortunately still had terrible sequelae. Finally, it's also important to explain to mother and father what happened. In the emergency, this will often not be possible because everybody is busy with just dealing with the emergency, but afterwards this has to be explained to them and also discussed for what will happen with future deliveries. So in summary, the shoulder dystocia is fortunately rare, but it's a terrifying obstetric emergency. It is not predictable, but quick recognition, call for help, and announcement of the emergency. So to say this, I have a shoulder dystocia in room 5 is very important. Swift multidisciplinary team response is important and following a systematic approach. And for these emergencies, multidisciplinary maternal obstetric drill training is very, very effective and important. So now if you have any questions, we will have a Zoom meeting and we can discuss the answers. But I do as well advise you to have a look at the, when you're going back to the university, pop into the skills lab. Miss Anha always is happy when students come to the skills lab. Pop into the skills lab and have a look at the delivery model to just kind of see how shoulder dystocia can be, to try the maneuvers for shoulder dystocia yourself. Okay, thank you very much for listening.